Welcome back to Conditions 2. We're in part 3 of 3. So we've just covered genetic disorders, and now we're going to look at both seizure disorders and dystrophies. Let's get started. First up is seizure disorders. And a seizure is a temporary involuntary change of consciousness, behavior, motor activity, sensation, or autonomic functioning. It's classified by clinical signs and symptoms, and also it is you can see it on an EEG or electroencephalogram. We have two different types, a generalized seizure and a partial seizure. We used to call them grand mal or petit mal. Now we call it generalized if it's all over the body, partial if it's a smaller form of seizure. Epilepsy is a chronic condition that is marked by recurrent seizures. When we think about different types of seizures, falling into the general category are tonic-clonic, so that's the seizure with a lot of convulsions happening. There also may be absence seizures where the individual seems to disappear. There could be some movement, but it's mostly this lack of attention and consciousness. There's atypical absence, myoclonic, and atonic. So just some terms for you to know if you're working with someone and they have seizures. There's also partial seizures, and there are a variety of different types. Simple, complex, and partial seizures are the most common type found in children. We have a couple other types of seizures which we'll see in pediatrics. One is infantile spasms. This happens between 6 and 24 months of age, and it impacts cognitive development. So it's a form of seizure that happens for that period, then it resolves, but it can very much impact cognition. The final type is status epilepticus, and this is a seizure that lasts 30 minutes or longer, and it requires medical intervention both to potentially stop the seizure activity and also to care for the child after they've had the episode. So status epilepticus can be very dangerous for a child, and it is most often treated with medication, large amounts of medication, and seizures. Well, we'll get to treatment, but those are the three types: generalized, partial, and then these other two. There is a protocol of emergency treatment for seizures. It's in your presenter notes, and what I'd like you to do is to read this and study it so that if you are ever seeing an individual with a seizure, you know exactly what to do. I'm not going to go through it with you in detail here, but I would like for you to know this information. All right, so treatment for seizures. The emergency protocol for seizures, which is in the presenter notes on the previous slide. Then we have anticonvulsive medications. The drawbacks of these, well, the positive is that they can control seizures, which is fantastic. The drawbacks are that they can be significant side effects in terms of attention, sleepiness, weight gain, a range of other symptoms. And dosage regulation can be difficult, right? So we have a child that's growing and changing their body weight at a pretty rapid rate, all things considered. So regulating the dosage due to that, and also just figuring out what is exactly the right amount that doesn't put the child into this very lethargic state, but is enough to control the seizures, can be difficult. A ketogenic diet is another type of treatment. And interestingly, people are going on ketogenic diets for their health. I won't comment on that, but the ketogenic diet is basically very, very high in fat. and protein. And the idea is that the fat is going to help build the myelination in the nervous system, and the myelination is going to insulate the nerves and the electrical system so that it reduces the frequency of seizures. I actually treated a child who was on a ketogenic diet, and she ate a lot of whipped cream, ice cream, butter, fatty meat, all sorts of products that were very high in fat. She also had terrible constipation, as you can imagine. So she drank a lot of smooth move tea as well. It did have some positive effects, but the diet is challenging in and of itself. The third treatment type is surgical intervention. And this is a last-ditch effort, right? So medication and diet are first. Surgical intervention comes later. Hemispherectomy, in other words, separating the two sides of the brain surgically so that those electrical impulses are not going haywire across the two hemispheres. Corpus colostomy. Sorry, I've lost my language at this point in the day. And let me back up. The hemispherectomy is the removal of part of one of the hemispheres. The corpus colostomy, keep thinking colostomy, but is this the same? No, I don't think so. Is a separating of the two sides of the brain, and then electrical stimulation of either the vagal nerve or the thalamus to help reduce the frequency of seizures. You'll excuse my botching of the surgical intervention. It's written down there. We got it right in the end. Thanks for your patience. It's hard to talk this much sometimes. All right, so that's about seizures. And remember, you want to look at that slide. It's number 34, and really drill into the emergency treatment. With regard to dystrophies, muscular dystrophies are a muscle disease. It's progressive weakness in various muscle groups. There's delayed development of motor skills. And different types, which we're going to go over in a minute, affect different parts of the body, and there's different rates of degeneration. Common types include Duchenne's, Becker's, limb-girdle, and fascioscapulohumeral. So here's a breakdown. In green, we see the limb-girdle. It's autosomal recessive, right? So it is a genetic disorder as well as a dystrophy. Initially affects the proximal muscles at the shoulders and hips. Onset is up to either childhood all the way up to 30, and it's a very slow progressing type of muscular dystrophy. Fascioscapulohumeral is autosomal dominant. Its onset is in the teenage years, and it primarily, as the name indicates, affects the face, the scapulas, and the shoulder areas. Becker's is a progressive form that's often fatal, but onset is later, usually 8 to 12 years of age. There's a genetic marker for it, so we know that there's a genetic component, and the signs and symptoms include generalized weakness. Then Duchenne's muscular dystrophy gets its own slide because we see it 1 in 3,500 children, and it only affects boys because it's X-linked recessive. So Duchenne's is the most severe form of muscular dystrophy. Onset is young, between 2 and 6 years of age. It is progressive. It starts at the pelvic girdle, it moves to the shoulder girdle, and then it involves all muscle groups. So pretty gnarly. Children with Duchenne's have difficulty rising from the floor, and they develop something called a Gower sign, which I'm going to show you a slide of next. There's also pseudohypertrophy of the muscles, And what this pseudohypertrophy means is that the muscles, and the calves are a pretty frequent place for this to happen. The calves look big and muscular and very well defined, but it's not muscular tissue that's in the calves, it's fatty tissues that's growing. So the pseudo, right? Pseudo meaning fake or false, hyper meaning a lot, and trophy meaning the development of. It's development, it's fake development of the muscles, basically. So in the calves look big and bulky, like you would be super strong, but it's not muscle tissue that's in there. Many boys with Duchenne's are in a wheelchair by about 9 years of age, and there is a shortened lifespan. I believe it's often into late teens through the 20s. There are 2 videos that are linked in the presenter notes, and you might watch them to see a picture of what Duchenne's looks like. And this is Gower sign. So typically, we would rise from the floor by, in picture 1, we're in quadruped. Then we would, in a typical individual, you would go into a kneeling position, a half kneel, and then a stand. Well, in the child with Duchenne's muscular dystrophy, the muscles are becoming so weak, especially around the pelvic girdle, the shoulder girdle, and this pseudo-hypertrophic paralysis of some of the muscles, that the child needs to climb up their body. So they go to a hands and feet position, and then hopefully you can see this, but so you're in a hands and feet position, and then they're literally climbing up their body to rise to an upright standing position. So it is a hallmark of Duchenne's muscular dystrophy before the condition progresses sufficiently that the individual winds up in a wheelchair. In terms of treatment for dystrophies, medications can be helpful, therapies including OT, breathing aids at the end of one's life, surgery sometimes. I worked with a young man, I think I started working with him when he was 13 and stopped when he was about 16. And he had a variety of surgeries. He developed really pretty severe scoliosis, and so he had scoliosis surgery to help him maintain an upright posture when he was in his wheelchair, because that was going to be so much more functional, and had a range of other surgeries. Therapy may be compensatory and focused on prolonging or preserving function. So think about it. We've mostly been talking about conditions like CP that's not progressive, and this condition is progressive. So what we focus on may be just preserving function, prolonging the individual's skills, and finding ways to compensate as they lose skills during the progression of the disease. So it's a very different mindset. It can be disturbing to think about, and that's totally normal. But, for me anyway, although it was evident that this young man was going to, die of this disease, probably, maximally in his mid-20s, I did feel like I had a valuable and useful role in prolonging the function that he had left, getting him some equipment that was going to make things easier, and helping him to compensate for the progression of the disease. All right. You've reached the end of Conditions Part 2. Congratulations. And I will be back with you for Conditions Lecture 3. But in the meanwhile, jot down any questions you might have. Please bring them to class or email me. If you want to see anything like what it looks like to have a Gower sign, etc., just let me know. We will watch videos in class as we're able, but I very much strongly encourage you to watch them on your own. And I thank you so much for your attention during this video. All right, everyone, take care. Bye-bye now. See ya.